Rheumatology Nurses Society, and we'd like to welcome you to today's broadcast of the Rheumatology Nurse Practice as we discuss RA and comorbid conditions with a focus on sleep issues and respiratory disease. Our panelist today includes the RNS President, Iris Zink. She is a nurse practitioner out of Lansing, Michigan. She just recently opened one of the first nurse practitioner-run rheumatology clinics in the country, and she is here with us. She is also a board-certified rheumatology nurse. We also have Elizabeth Kirchner, or Betsy Kirchner. She's a nurse practitioner at the Cleveland Clinic. She's also a board-certified rheumatology nurse, as well as the Education and Curriculum Chair for the Rheumatology Nurses Society as a board member. Our guest today is Rebecca Thorne, and she is a nurse practitioner at the Cleveland Clinic and the focus of sleep and sleep issues. So we'd like to welcome you to today's broadcast. You can ask questions in a couple of different ways. If you're watching the recording of the broadcast, you're always welcome to go to the rnsnurse.org website and click on Contact Us and submit questions, and we'll be more than happy to reply to those. If you're watching live, you'll see a link on the screen. I'll try to say it out, but you'd be best off just typing it out. It's goo.gl/slides/CHGWPY. You can also ask questions on Twitter using the hashtag RNP16, and you can also text your voice messages in using 267-689-8495. So without further ado, I'd like for us to get to our panelists today and learn about comorbid conditions in RA, focusing on sleep and respiratory.
Hi everyone, this is Iris from Lansing, Michigan. I'm going to discuss today helping patients sleep at night and breathe during the day, which is the focus of the next edition of the Rheumatology Nurse Practice newsletter. And we're going to really just talk about sleep issues that our patients have and what we can do to help with those. So we know that there's an educational gap with sleep issues in RA, and I thought I'd let Betsy talk more about this. And so here's Betsy.
Thanks, Iris. You were trying to steal my slides.
No.
Do you want to go back and do a little bit more of the content, or should we just go right into it? No,
we're just going to go right into it. I think they'll get it when we're talking. So.
Okay, that's good. Okay, so the name of this slide is patient education, but really it's everyone's education for sleep issues in RA. Patients don't know, a lot of clinicians don't know that 4 out of 5 RA patients have some degree of disrupted sleep for multiple reasons. The newsletter does a great job of going into a lot of the different reasons, but it's important for the patients to know that it's common and they're not alone and they can ask us about this. It's part of our whole scope, so we want them to know that, and we want clinicians to know that it's an issue also. There are multiple causes of sleep disorders in patients with RA. There are comorbidities that go along with it. And we are going to have a pop quiz for Iris and Becky, if she wants to be on the pop quiz. All right, Scott. All right, Iris, Becky, who's that?
It's a very handsome older gentleman. I don't know that.
Remember last time it was the guys from MASH, the pros from Dover? That was the pop quiz. Now this time, this is Dr. John Hickam, who came up famously with Hickham's dictum, which is patients can have as many diseases as they damn well please. So there's Occam's razor, which says you're supposed to find one unifying diagnosis, and that's the simplest explanation. Dr. Hickam said, no, patients often and you have many causes of their complaints, and you can't just get to one and stop. Okay, so Scott, we can go back to the real slide now. Quiz is over. So that being said, that the education part of the sleep issue here is that, so a patient comes and says, I'm tired, I'm not sleeping well. Why aren't you sleeping well? Well, because I'm up 7 times a night to urinate. Slam dunk, right? Send them to urology. You get their probably BPH taken care of, and they're sleeping better, and they think it's great. And then they're kind of afraid to bring it up again. And they're afraid to bring up that they're having early morning awakening. And, so maybe it's a little bit of depression causing their sleep disorder. Or we forget to ask them, do you snore? Do you wake up gasping? Does your partner report that you snore at night? That kind of thing. So just because, with sleep, it's almost always multifactorial. You can't just get to problem number 1 and then stop, end of story. You got to keep digging. You got to keep going, keep asking. The other big patient education issue for sleep is that fatigue is not the same thing as sleepiness. So a lot of times you can avoid unnecessary referrals to people like Becky if you find out that it's really more of a fatigue issue, and that might be their uncontrolled RA or many other reasons, versus they're actually falling asleep, at a red light. They're falling asleep, during the day, that kind of a thing. So you sort of have to tease that out before we start digging into or sending people out for different referrals. And then the last thing is, I'm sure we're all asked, and we've had lots of experience with this. I'm not sleeping very well. Can I have some Ambien, Xanax, temazepam, whatever? In the education piece, it's really a lot better to find and treat the cause than to just put a Band-Aid on it and do a quick fix with a sleeping pill or sleeping aid. Okay, so that's a little sleep education issue, and then we'll move on. It's very similar with respiratory disease in terms of it's not uncommon to see in patients with RA. And so this isn't so much education, it's more clinical pearls. Just to remember, for all the clinicians out there, we all know RA is not just a joint disease. And so we have to remember to ask our patients. They're not thinking of their lungs when they come to see us. They're thinking of their swollen joints and the fact that they can't do what they used to do. They can't play the piano or whatever. We need to ask them, are you short of breath? Can you go up a flight of stairs? We have to talk to them in language they can understand, not just, do you have dyspnea on exertion? Who's going to get that? You have to say, what happens? Can you get to the top of a flight of stairs without feeling short of breath? Can you walk a block? So it really should be part of almost every visit that we ask them about these respiratory symptoms, because it goes along with our diseases, and we need to take ownership of that and get them referred to the appropriate place for PFTs or respiratory consult or CTs or whatever it is we need to do. And then for the really high-risk patients who do have those comorbidities, we might consider periodic screening. Depending on their presentation, it could be, like I said, PFTs, yearly PFTs. It could be a yearly CT scan. If you see something abnormal, it might even be more frequent than that. But that is sort of the biggest issue with respiratory and RA, is to just sort of get it out there, let them know that this is part of the whole process, and we need to address it. You can't let it get past us. So that was all I really had about from this issue, sort of the points I wanted to pull out and discuss. What about Iris? Do you get sleep issues a lot? You answer that while I turn this phone off behind me.
I do, and I really hope that Becky's going to give us some pearls, because it's hard enough to get all of the RA information answered from the patient during the visit, but when you have to go into the whole sleep hygiene and using your laptop in bed and everything, there should be a quick 3-question quiz that you can give to the patient to see what's really going on, and I hope you're going to give us some pearls with that.
What about respiratory? Do you get a lot of that in Lansing?
Well, yes, they're because of the obesity problem for sure. And I just simply asked, does your bed partner say that you snore? And if that's a deal, then, but I've seen patients who already have clubbing of their fingers and they were never diagnosed with sleep apnea. So, it's just about looking at the whole picture, like you said, that we need to do as part of our physical assessment.
Okay, now what about, how do you decide if somebody's high risk? For me, the obvious is they're smokers.
Right.
That puts them at high risk for both things, sleep apnea, sleep disorders, and respiratory issues. Is there anything else that sort of jumps out at you that would be high risk, where you'd say, I'm going to keep a closer eye on you for either sleep or respiratory?
I think definitely if the patient has really advanced RA. So if they have end-stage RA or they have rapidly progressing RA, then I'm going to think more lung. And so those are going to be my concerning patients. And then up here, because most of our patients work in and around factories, I think that would be another risk factor as well.
Okay, it's pretty similar down here too. Those are the things that jump out. You want to do a case?
Sure.
Okay, Becky, you want to do a case?
Absolutely.
Oh, good.
Here it is. Alrighty, so I chose to go with a postmenopausal female with rheumatoid arthritis that you all sent over to the Sleep Disorder Center. She has multiple sleep issues, no surprise there. Some of her complaints are difficulty falling asleep and staying asleep. her restless leg syndrome has gotten worse. She's been told she snores. And so the interesting issue of fatigue and sleepiness that Betsy brought up, you know, people describe it differently. People, a lot of times they'll say they're tired. You know, you really do have to tease out what they mean by that. And some people are not really sleepy who they may have really severe sleep apnea, and they may really not describe it as sleepiness, even if you test them further by doing a scale. One of the things that I found interesting when I was preparing for this is that a lot of the research seems to show that the patients with RA complain more of fatigue than sleepiness, and that compared to, let's say, someone with fibromyalgia who has complaints of both fatigue and a pretty high sleepiness score. So I don't know if you all see that in practice. It was something that I came across pretty frequently. So certainly looking at the two. I probably underestimated here the percent of patients with sleep complaints, even higher with the slide that Betsy showed. Obviously, there's that bidirectional relationship with pain and sleep, and so it's kind of the chicken or the egg, and so we certainly have to keep that into account with the rheumatoid arthritis patient. Really important, one of your past talks was on cardiovascular disease and rheumatoid arthritis. Certainly, patients with untreated sleep disorders, especially obstructive sleep apnea, have a significantly higher risk of hypertension, heart attack, stroke, heart failure, atrial fibrillation. So it's really important that we address the sleep issues in your patients for that reason, as well as sleep deprivation leading to increased inflammation. So there's question of basically being sleep deprived with sleep apnea. You're really setting up a pro-inflammatory response throughout the body. And so hopefully we can then address inflammatory conditions as well as hopefully prevent them if we get people treated early enough. There is some evidence for some RA being due to untreated sleep apnea, as well as the question of a disease like narcolepsy being an autoimmune disease. And then I'm curious what you find in your practice as far as patients with RLS. I mean, I came across the number of maybe up to 30%. I don't know what you all find. Do you think it's around there? Less?
I think it could be 30%. I would say off the top of my head, it might be a little lower around here. Mm-hmm. But if somebody laid out the numbers in front of me and said, look, it's 30%, I guess I wouldn't be too surprised.
Mm-hmm. Mm-hmm. Yeah. So, I mean, obviously really common. People will question, well, why is restless legs a sleep disorder? But it really does have that circadian rhythm to it where it really comes out in the evening. And so that's something that we'll talk about too. Okay.
Don't you think that's related to the whole, anemia caused by the RA, which is then exacerbating the iron, which is then could be exacerbating?
Yep, absolutely. Definitely related to the iron. So like on this slide, you'll see the labs for RLS. So the big thing is the ferritin to check the iron stores in the brain, because that's certainly going to be the number one issue with these patients. So trying to get their iron levels up should help with the RLS. So we do, when we first see a patient, we certainly do the full history and physical. And then I tried just to focus here on what we're doing sleep-wise. We do a lot of patient-reported measures actually before every visit, much to the dismay of our patients, because it takes quite a while. But it can be really helpful to follow along those numbers. And so these are just some of the ones that we use. I know we're going to show an example of the Pittsburgh Sleep Quality Index later, which covers a variety of issues. But it can be really helpful to look at the sleepiness scale, the fatigue scale, insomnia, RLS, and kind of see how significant is it. Does it correlate with what the patient's telling you? And then to look at it at follow-up. Sometimes when patients come in, I find they'll say, oh, I don't really feel that much better. And then if you can show them that that number's improved, that can be kind of nice. So for the sleep history, you're right. I mean, it can take an hour to do this initial visit, and you're trying to do sleep in, 2 seconds. I think that certainly the things like the snoring, like if you think about the stop, bang that we sometimes use in sleep, sometimes that's a quick way to look at risk for sleep apnea. With the snoring.
You have to tell us what that is, Becky.
It's snoring and tiredness. Now I'm probably going to forget what it is. Gender, neck size. I'm forgetting a few here. But that can be kind of a quick and dirty, and so way of getting an idea if they're at high risk. But you may not even need to do that. I mean, if they snore, I don't know how. If you have a lot of obesity in your population, yeah. I mean, we certainly do in what we see, and then the frequently interrupted sleep, like you said, there are a million different reasons for that. Even nocturia, the urologist can't fix. That can be sleep apnea. A lot of times, nocturia is greatly improved by treating their sleep apnea. So that's off on a tangent, but that's one of my main pearls. So people are very happy when you get that better. So with their history, we're looking at, asking them everything from what time they go to bed, how long it takes them to fall asleep, how often they're waking up, can they fall back asleep, when do they get up in the morning, is it hard to get up, naps, total sleep time for 24 hours, any medications they've used in the past, especially for insomnia, which, that certainly can be a really long list, because people do often, they're frustrated, they're anxious, they need sleep, they're exhausted. So a lot of times, people reach for a medication and it's not necessarily the best option. The sleep hygiene, you're right. I mean, you could spend a long time working on sleep hygiene with people. So this, in a way, it's kind of more treatment than assessment, but things like, the phone and the tablet in the bed, watching TV in the bed, watching the clock. Physical, we do a full physical. Certainly one of the things we're really looking for is a crowded airspace. So doing an oral exam, head and neck exam, nose, really to see if they have really the characteristic findings of someone with sleep apnea, where it's just a very crowded oral space where you can't really necessarily even see their tonsils or uvula very well. Doing a neuro exam too. Sleep diary, that can be especially helpful in insomnia, I think, and we can talk a little bit more about that. The labs, definitely the ferritin, the iron, the transferrin saturation. A lot of times we'll do things like a TSH, a vitamin D, but definitely the ferritin being the big one. And then, of course, there's the question of sleep study. So there is always the in-lab sleep study versus the home sleep study. And I don't know if you all order sleep studies. Certainly if that's certainly a way that you can utilize me, is by asking what might be the best sleep study to order for someone. Some insurance plans will require that you do a home sleep study. So in that case, you're probably stuck doing it, even if it's not necessarily the best test for that person. If they're morbidly obese, the home sleep study is not the best. But if you really have high suspicion for sleep apnea, then that can be a good one to do. We get certainly a lot more information in the lab. I think it's probably especially important for these patients with really being able to thoroughly evaluate their oxygen levels. Mm-hmm. That's going to be important, and their limb movements too. So the in-lab sleep study, and then the question of the titration study to determine CPAP, and everyone's favorite. So, and there's just an example of one of those patient scales that can be done. Okay, so just obviously ask any questions along the way, but what I was gonna kind of focus on was that this person turns out she has moderate obstructive sleep apnea, And the reason that I wanted to deal with that first is because a lot of times if you treat the sleep apnea, you will get improvements in the other issues. So you'll find that the sleep onset insomnia can improve. Certainly the interrupted sleep improves a lot. The restless legs can improve once the sleep deprivation is better. Interestingly enough, independent of iron, sometimes you'll see that improve too. So what we want to do is get their sleep apnea treated. CPAP, positive airway pressures are gold standard. Certainly not everyone's favorite, but it's what we try to get most people on, and then we have other options if need be. As far as insomnia goes, because that's certainly the number one sleep disorder that we see. I'm sure every generalist and every specialist comes across that. So if you happen to give Ambien and it works, great. But there are some other options that they involve more commitment from the patient, but they can be more effective than medication, and that would be cognitive and behavioral therapy. Mm-hmm. So we do have sleep psychologists. We're very lucky here at the Cleveland Clinic. We have some real experts who they do individual counseling, they do group counseling for insomnia, and there is actually an online program that has very good success rate. Really better than medication as far as efficacy goes. And that's called Go to Sleep. And so people can sign up and do that online at home, which some people prefer, to having to make a trip to Cleveland. So those are some options. Let's see. Let me look at my cheat sheet and see if I have anything else. Any other questions or thoughts?
I'm just always surprised, Becky, about how many patients tell me they sleep with animals, like lots of animals.
Lots and lots, yes.
I don't know how they sleep when they have four or five dogs on their bed. I mean, that seems logical.
I know. Well, I don't know. I'm guilty too. I have one or two dogs.
Lady.
And so I don't always practice what I preach. But you're right. I mean, it's a matter of what they're willing to give up, definitely. That's tough. Sometimes I'll tell people that's fine. If watching TV helps you, fine. We'll kind of barter over what they're willing to give up.
Right.
I think the tablets and the phones are a huge issue. I mean, people are not willing to put those down. And then the light is just going to stimulate wakefulness. So that's one of the biggest issues. And clock watching, they need to cover up their clock or turn it around because it's very anxiety provoking to keep looking at the clock.
And what about the whole movement towards all natural? Becky, what do you do about that?
I don't think there's really not evidence that using natural supplements is helpful. Something like melatonin can be helpful, but actually more for some other sleep disorders versus insomnia. It's not necessarily the best drug for insomnia. It can help when people have a sleep phase delay where let's say they're night owls, but they need to not be night owls because they need to get up in the morning and go to work or school. So it can be useful for some other things. I really think, there's a role for prescription medications for sleep, and there's certainly a lot of different options. But I think it has to be done in conjunction with the sleep hygiene.
Mm-hmm. What about you, Betsy? What do you think? Do you use medications for your patients? I mean, where is that fine line of giving up here, just take your Lunesta versus can we work on this?
Yeah, exactly. If they've been, if they've tried really hard, if they've maybe even been over to the sleep center, and there's really no organic cause, and then sometimes I will sort of let them do cycles. Say try it without. If you have a night or 2 nights of bad sleep, everyone has a night or 2 nights. If you're going to 3 or 4, then go ahead, take some sort of a benzo or sleep aid, whatever it is, that they've tolerated in the past. But if they're getting into needing it all the time, then they need to go back and, we need to hit the reset button, because as far, in our experience, you just can't stay on these things long term without some sort of consequence. especially with the drug-drug interactions with all the other stuff we use. And especially if, you know, they're these long-term rheumatoid patients and they have all this damage and they're on opiates, you know, just to function, then the benzos really, really start raising red flags. So for them, then we would probably send them back to poor Becky and say, look, you know, this what we're doing now, it was working for a while and now it's not working anymore. Do you have any other suggestions? Do we need to retest anything? Is there something we missed?
And it's always nice if you can kill two birds with one stone and treat pain. I don't know, you know, with something like gabapentin or amitriptyline. I always try to think about, do they have something peripheral neuropathy or something that I can treat, you know, two things with one medication.
Yeah, take advantage of the side effects instead of...
Right. Mm-hmm.
And Becky, do you have any advice about patients who just claim that they're addicted to these sleep medications? And what do we tell them about the long-term consequences of using these?
I mean, a big problem can be that they can develop tolerance, and so they're not going to work every night. So sometimes we'll even cycle and have them use a medication a few nights a week and use something else the other nights a week, because we certainly have patients who they're probably going to be on medications for the very long term. So we try to make the best of it with them. I mean, we try to always go back to the side effects and risks versus benefits. And if you're having things like, you know, sleep eating and you're gaining weight and your sleep apnea is getting worse, well, obviously most people that the weight gain is a side effect they really don't want. So trying to utilize that as a way to maybe change to a different category of medication or revisit the cognitive and behavioral therapy.
Mm-hmm. And what about like memory loss or anything like that with long-term use of Ambien or Lunesta? Is that something that we need to really worry about? Is that?
I mean, I think it's not, we don't know for sure. I mean, certainly plenty of people will have a sort of a short term, you know, where they don't remember basically when they take it at night, they don't remember then from that point to going to bed, which is bothersome to most people, but there are people that's not bothersome to. So, you know, we discuss it and go from there basically.
Right. Okay. Do you have anything else to add, Betsy?
I don't think so. Guys, do we have any questions from the rest of the world right now?
Right now, I'm checking the line. It does not look like we have any active questions, but it's definitely a fascinating topic, you know, for sure. I'm sitting here learning and thinking about my circadian rhythm and wondering where it went to. So.
Oh, wait, I have a question actually for Becky. So
Okay.
Becky, if they have restless legs and we check an iron ferritin, you know, and it's low, how long do we give them? What are we shooting for on their labs before we say, okay, that didn't fix it?
Yeah. A ferritin of at least 50, maybe above 75. And so, you know, they certainly may need to be on a dopamine agonist. I mean, they can be very effective. The medicines like the gabapentin or the pregabalin. Interesting, and opioids actually can be very effective. So I suppose that would be something to think about with your patient. I mean, do you have a lot of patients who are on opioids for their RA?
Yeah.
I don't.
Yeah.
I don't anymore because I can't prescribe them. So that kind of eliminated a lot of population.
I guess a lot is relative.
Okay.
There's a core group where, you know, we've done the physical therapy, we've crossed all the T's and dotted all the I's, and this really is improving their quality of life, and that's what they're going to be on.
Right.
The benefits outweigh the risks.
Sure, absolutely. So that could be something to consider also, the killing two birds with one stone thing, you know, with treating their RLS too.
Okay. But first try and get the ferritin to 50 to 75. Okay. Thanks.
I think I see that the most in my gastric bypass patients, for sure. You just cannot get those iron levels up, and then they're constantly bothered by this.
Yes. Yes, that is for sure. I mean, I think there will probably be more use of IV iron in the future. We probably underutilize it, but I think that will probably be something to look for.
Okay.
Great.
You know, restless leg syndrome is worse if you're a dog. I just want you to know that, because when you have 4 legs, Mhm. That's how we're ending it, Kevin, right there.
Nice segue into nothing. As well, we want to thank our panelists today. This is a great start of a dialogue, and definitely sounds like there's plenty of information to start digging into and taking a look at how sleep issues and respiratory issues affect not only patients with RA, but all the rheumatologic conditions. And so we want to thank you, panelists, for joining us. Keep an eye out for new information coming out over the end of this year as well as 2017. Rheumatology Nurse Practice is a grant-funded operation and grant-funded initiative through the RNS, and we'd like to thank our supporters, Pfizer and a lot of the other supporters that come in and support these types of activities that we can make available for you. And the whole mission and vision, wow, I'll say that right, for the Rheumatology Nurses Society really is to ultimately produce the best level of education possible for rheumatology healthcare professionals for the best possible outcomes in your patients. And we thank you for visiting with us today. This will be available for replay on our website as well as YouTube, and you can also find it on Facebook. Also, you can sign up to receive the Rheumatology Nurse Practice publication on our website at rnsnurse.org/RNP. The most recent version is on pain management in RA, and we have some great additions coming up after that. You also check out our membership options on Rheumatology Nurses Society's website, rnsnurse.org, and we would love to have you consider becoming a member and look for our 10th anniversary conference next year in August 2017, 10 years. So we thank you, panelists. Would you like to have any closing words as we sign this off?
Well, thanks for having me. I have to say I'm jealous. We don't have an organization like this in sleep disorders.
Wow. You can come and be part of the Rheumatology Nurses.
Yeah. Okay, thanks.
We like that a lot. Kevin, I think it'd be easier for you to speak clearly if you were getting better sleep. So let's just...
Probably so.
Yeah.
Awesome.
Thank you so much for joining us today. It was awesome.
Hey, thank you all.
Thank you. Bye.
Bye.